Unfortunately, actually, I got held up and I'm right now in my car. I just parked my car. And anyway, today's, I hope it's going to be a great discussion. ABC of CBC, the theme topic will be discussed by Dr. Mamta Manohar. She's actually senior resident family medicine at Government Medical College, Calicut. And the chair for the session will be Dr. Akhil. Sir has done his MBBS and DNB from Calicut Medical College. He is an excellent academician, and he's very well known among his students, and he's a wonderful clinician as well. And I would like to, on behalf of State Spice Route Kerala, I would like to welcome you all, and I would like to extend a warm welcome to Dr. Akhil, and also best wishes to Dr. Mamta for this session. I hope all of us will benefit from this, because even though CBC is something which we routinely send for almost every other patient, still when we get a result, sometimes even I wonder what is happening here. So I think this will be a very informative session. I hope all of us will benefit from this. Yeah, thank you. Over to the state lead, Dr. Nadeem.
I think he's chairing the session. He'll introduce. Thank you, sir. Over to Dr. Akhil.
Can I start the session?
Yeah. Akhil sir is here, na? Dr. Mamta.
Yeah, sir. Akhil ka join cheyidittundu, but I think his video and audio is off.
Okay. Dr. Akhil, mic unmute ചെയ്തിട്ട് സംസാരിക്കും. Mamta, you can start, it seems.
Hello. Hello, am I audible?
Yeah, well audible.
Yeah. As we are short, I'm Dr. Akhil, assistant professor in medicine, Calicut Medical College. And thanks to Ali for the introduction. And since we are short of time, I think we'll straight away go to the session. I think it's as far as family physicians or general practitioners are concerned, I think this is a very important topic. Maybe the more, I won't be exaggerating if I call it the most important medicine for a general practice or a family physician. And of course, even for a hemato-oncologist, because you give a lot of it. If a CBC is properly analyzed, I think it can give you very much information that even that a peripheral smear or even a bone marrow can provide you with. And sometimes a proper interpretation of a CBC can sometimes even do away with the need of doing a bone marrow, because the CBC analysis itself can give you a proper diagnosis from just a proper analysis of the CBC. And I think we have a very apt person to speak on this, Dr. Mamta, my long friend, junior colleague at Calicut Medical College. She's one of the first of MD Family Medicine Calicuts from Calicut Medical College, which incidentally is the first institution to have MD Family Medicine. And I'd also like to mention that she's a very good academician and a very patient-friendly person, and somebody who is also has an expertise in HIV medicine, also having been in charge of the HIV clinic under General Medicine Department of Calicut Medical College. And I hope she'll be able to throw a light on an overview of the interpretation of CBC and some amount of troubleshooting and certain aspects which have to be kept in mind when you analyze a CBC, because sometimes you may go wrong with the interpretation if you don't keep these aspects in mind. So that's all. Over to you, Mamta, and best of luck for a very hopefully productive session. Thank you.
Thank you so much. Good evening, everybody. Without any further delay, I would go on to the topic, and I thank Spice Route Kerala for giving me this opportunity. I also thank Dr. Akhilka for giving this wonderful introduction. So, without any delay, I go on to my topic, interpretation of complete blood count. Complete blood count, as you all know, is a series of tests which is used to evaluate the composition and concentration of various cellular components of blood. And it is the most basic test, but it is the most informative single investigation which can give information on the blood, marrow, health, and disease state of another organ. I'll be dealing as what is CBC, why CBC, various parameters, the variations in CBC parameters, and how these variations affect the assessment and care of patients. So this is a picture of a hemogram. A complete blood count routinely includes hemoglobin, hematocrit, RBC count, RBC indices, WBC and platelet. And you can also see there is a histogram of RBC, WBC and platelets. Now, why is CBC important is that it is used to diagnose various conditions like anemias, hemoglobinopathies, bone marrow aplasia, nutritional deficiencies, thrombocytopenia, autoimmune conditions, infections, parasitemias, malignancies, and drug response. Before going to the topic proper, most important is a proper history taking and clinical examination is the cornerstone in the interpretation of CBC result. Now coming to the sample collection, under aseptic precautions after taking informed consent, blood is collected directly into commercially prepared negative pressure vacuum tubes, which are the Vacutainer tubes. And for this CBC collection, we use purple colored tubes, which contains the anticoagulant EDTA. Earlier, we used to have bottles and we fill the EDTA into it. And this amount of anticoagulant is very essential because this can affect the size as well as the volume of the cell. But before a specimen is obtained, we have to have a careful thought on what studies are needed, and that will help in the interpretation. And communication with the lab personnel is also important in proper handling of the specimen. We have to keep in mind that factors such as activity, hydration, medication, age, sex, smoking, anxiety may affect the hematological parameters. The anticoagulants commonly used are heparin or EDTA. If we are processing the sample within 8 hours, we can keep it at room temperature, but up to 24 hours, if you are using, the sample should be refrigerated, and more than 36 hours, ideally, the sample should not be used for testing. So this is the modern automated cell counter, which is available in almost all the labs. It processes approximately 60 samples in an hour with an accurate analysis of 18 parameters in blood. Earlier, the manual methods used to give only the cell count, but with this, we can measure the cell volume and the variation in cell size. So the components of this are a diluent, which is ammonium salt, a lyser, which is sodium chloride, which lyses the RBCs and preserves the WBC. There is a detergent, as I already explained, there is Vacutainers with the anticoagulant EDTA. Now, how the machine works, just for completion's sake, one part is taken and it is lysed for hemoglobin estimation by photocolorimeter. The second part, you can see the R is marked. This is for RBCs and platelet parameters. And after the RBCs are lysed, the third part is taken for WBCs. And then the machine displays and prints the result. So this is in short of how it is done. This is in first, the specimen is collected, the machine aspirates it, and as I already said, it is split into 3 channels, and then finally it is given as the print. Now the 18 parameters which are given are these, and now the newer one is a 5-part counter. This gives 23 parameters. The only difference with the other is that here the monocytes, eosinophils, and basophils are given separately, and their absolute numbers are also given. Now, these are the certain legends which you see in a CBC report. If it shows an exclamation mark, it means that the data is out of the linearity limit. If it shows plus, it means that the data exceeds the upper mark. If it shows minus, it means it exceeds the lower mark limit. And if there's a star, it shows that the data is low on reliability. Now, these are the normal values of RBC parameters. I'll be dealing it in the slides. And these are the normal values of the WBC parameters and platelet parameters. Now coming to the components of complete blood count. The first one is the red blood cells. Among this, hemoglobin. As you all know, hemoglobin is the measure of the oxygen carrying capacity of blood. It is expressed as gram per unit volume. Normally in males, it is 13.5 to 16.2 gram per liter. And in females, it is 12 to 16 gram per liter. Both high and low hemoglobin count, it indicates a defect in the balance of red blood cells in the blood, and there may be some disease. So as I said, it is detected by the spectrophotometer or colorimeter, and it is based on the sign methemoglobin principle. Hemoglobin, as you know, can be decreased in blood loss. Blood loss can be through any route. Most importantly, it can be GI blood loss, hemorrhoids, ulcers, colitis, menorrhagia or hemorrhage, which can be acute or chronic hemorrhage. It can be deficiencies, any vitamin or mineral deficiency, most importantly, iron, folic acid and B12 deficiency. Chronic diseases of the liver, kidney, chronic inflammatory conditions like rheumatoid arthritis. And bone marrow insufficiency, it can be infiltration with tumor or tuberculosis, toxic immune or drug reaction. Hemoglobin can be increased in polycythemia vera, high altitude adaptation, obesity, smoking, pulmonary pathology like chronic obstructive pulmonary disease, and most importantly, dehydration as might occur with prolonged or severe diarrhea, and emphysema or other long-standing respiratory diseases. Now, polycythemia approach I want to highlight because nowadays we get a lot of reports with high hemoglobin count. And when you get a high hemoglobin, the first thing you have to rule out is spurious polycythemia. That is an apparent increase in hemoglobin or the red cell mass. This is mainly because of dehydration. Once you have ruled out that, it means it is true polycythemia. True polycythemia can be primary or it can be secondary. Primary is after myeloproliferative diseases like polycythemia rubra vera. And secondary is associated with hypoxia, chronic lung diseases, high altitude smoking, and nowadays obesity, that is recent weight gain, and increased erythropoietin due to any other reason like renal tumors. How to differentiate between the primary and secondary is that in primary, like in polycythemia rubra vera, clinically the patient will have splenomegaly and all the cell lines will be affected. Whereas in secondary, there will be no splenomegaly and only the hemoglobin is affected. Next is hematocrit. Hematocrit is determined by a microhematocrit centrifuge. It is a measure of the solid elements of blood volume in whole blood. It is calculated as mean corpuscular volume into RBC and it is expressed in percentage. In males, it is 38.8 to 46.4 and in females, it is 35 to 45%. Now the variations, as I already said, it can be increased in polycythemia, hemoconcentration states like burns, diarrhea, kidney tumors like when their renal carcinoma, when the erythropoietin production is high, core pulmonale and pulmonary fibrosis. It is decreased in anemia, hemorrhage, hemolysis and bone marrow failure. RBC count is a measure of the red blood cells per microliter of whole blood. In newborn period, it is 4.1 to 6.1 million. In children, it slightly reduces, that is, it becomes 3.6 to 5.5. In adult, it reaches those of the newborn level, and in pregnancy, it is slightly lower, maybe because of hemodilution. The causes of decreased RBC count, it can be because in the production abnormality like iron deficiency anemia, B12 deficiency anemia, aplastic anemia, or red cell aplasia. It can be increased RBC destruction as in hemolytic anemia or blood loss due to any cause and hemodilution. Increased RBC count occurs in polycythemia vera, smoking, high altitude, renal neoplasia, heart failure, and some heart disease like congenital cyanotic heart disease, lung diseases like emphysema, dehydration, and rarely erythropoietin doping by athletes. Now the next one is mean corpuscular volume. Mean corpuscular volume is the mean RBC volume in whole blood. It is calculated as hematocrit into 100 divided by the RBC count. And normally it is MCV is 80 to 100. If it is less than 80, it indicates it is microcytic, and more than 100, it is macrocytic. Now, normal MCV, the conditions are usually iron deficiency anemia, we find microcytic anemia, but initial stages, they can have a normal MCV. Following acute hemorrhage, dimorphic anemia, hemoglobinopathies, aplastic anemia, endocrinopathies, mostly hypothyroidism and hypoadrenalism, though hypothyroidism can have macrocytic as well. Anemia of chronic disease can be chronic infections, neoplasm. Again, anemia of chronic disease can be microcytic. So the common causes are bleeding, nutritional anemia, hemolysis, and anemia of CKD. By history, we can easily rule out bleeding and take a detailed dietetic history to rule out nutritional anemia. And if you're suspecting hemolysis, we can do LDH, indirect bilirubin, and reticulocyte count. Next is low MCV. Low MCV is seen in conditions like iron deficiency anemia, thalassemia, lead poisoning, and sideroblastic anemia. Most importantly, iron deficiency anemia and thalassemia. In iron deficiency anemia, there is low or normal hemoglobin, there is low MCV, there is reactive thrombocytosis, that is platelet will increase, and there is increased RDW. This is associated with a dietetic history and examination finding like flat nails, longitudinal ridges can support iron deficiency anemia. And you can even look serum ferritin, which will be low in iron deficiency anemia. If normal, you have to think of a possibility of thalassemia. In thalassemia, MCV will be low, but RDW is normal. And this can be confirmed by doing a hemoglobin electrophoresis. Next is high MCV, that is macrocytic anemia. It is seen in conditions like alcohol, B12 and folic acid deficiency, pernicious anemia, as I already said, hypothyroidism, chronic liver disease, post-hemorrhage, hemolytic anemia, and certain drugs. In this, B12 and folic acid deficiency and pernicious anemia cause megaloblastic macrocytic anemia, and all other are cause of non-megaloblastic macrocytic anemia. Dimorphic anemia, that is you get two population of cell occur in mixed anemias when there is combined iron and B12 deficiency, iron deficiency when it is responding to treatment, sideroblastic anemia, and following blood transfusion. Next is mean corpuscular hemoglobin. It is the amount of hemoglobin per RBC. It is calculated by hemoglobin by RBC count into 10, and normal is 26.7 to 31.9. Any conditions, as we said, when anemia, hemoglobin decreases, the mean corpuscular hemoglobin also decreases. Mean corpuscular hemoglobin concentration, it is the concentration of hemoglobin per unit volume, that is 100 ml of packed RBCs. And it is normal is 32 to 36. It can be either expressed as percentage or gram per deciliter. And mean corpuscular hemoglobin condition is characteristically increased in hereditary spherocytosis. Now, red cell distribution width, it is often ignored, but it's a very important hemogram finding. It estimates the RBC size variability, that is anisopoikilocytosis, and it becomes abnormal earlier in nutritional deficiencies, especially in iron deficiency anemia. It is expressed as coefficient of variation and a standard deviation. So when we take the peak of the cell as 100%, the width of 20% from the baseline is taken as a standard deviation. That is 30 to 50 femtoliters normal. And coefficient of variation is taken 68.26% from the peak. And its normal value is 11.5 to 14.5%. We normally look the RDW-CV, that is coefficient of variation. Next is white blood cells. In the first few days after birth, polymorpho-neutrophils predominate, but afterwards lymphocytes are predominantly seen. And this persists for about 4 to 5 years of age. WBCs are used to support a diagnosis of any infection or inflammatory purpose. You can see the WBC as they give either the total count or the differential in percentage or as whole numbers. Now, leukocytosis, a high white blood cell count, it usually indicates a response to an infection. As you all know, bacterial infection. It could be a reaction to drug, as in steroids. It could be a disease of bone marrow, as in leukemia, or an immune system disorder. So whenever you get a high WBC count, you have to see which one of us is affected, whether it is neutrophilia, eosinophilia, monocytosis, basophilia, or lymphocytosis. Either of these, it can be either reactive or neoplastic. Neutrophilia, we know it can be acute bacterial infections, leukemia. Eosinophilia in allergic conditions, worm infestation, adrenal insufficiency, tropical pulmonary eosinophilia. Basophilia in allergic reactions, CML, and hypothyroidism. Monocytosis in infections, tuberculosis, monocytic leukemia, collagen vascular disease. Lymphocytosis in viral infections, lymphocytic leukemia, tuberculosis, and infectious mononucleosis where you get atypical lymphocyte. Next is leukopenia. We have to remember 4 common causes for leukopenia. Could be drugs, it could be infections, autoimmune diseases, nutritional B12 and folic acid deficiency, and lastly malignancies, that is myeloproliferative disease. They can present as single lineage cytopenias. Neutropenia is most relevant when it is less than 500 cells. And as I already said, the most frequent cause are drug therapy and infection. In addition to that, you have to rule out immune, nutritional deficiency, and myeloproliferative disease. Eosinopenia can be seen in stress, inflammation, Cushing syndrome, steroids, or drug. Basopenia also in acute infection or treatment with steroids. Lymphopenia can be seen in immunosuppressant drugs, corticosteroid therapy, viral infections, especially HIV, immune deficiencies, marrow suppression, autoimmune diseases, and tuberculosis. Coming to the next is platelets. When you get a low platelet count, first thing you have to exclude is spurious thrombocytopenia. That is, either it is due to a platelet clumping or satellitism. And this can be confirmed by either doing a manual platelet count or using sodium citrate as the anticoagulant. Now, the causes of thrombocytopenia is very important. The most common ones are drugs. It can be antibiotics, anti-inflammatory agents, anti-neoplastic, viral infections. Any viral infection commonly we see now is dengue fever. Nutritional deficiencies, most commonly now seen as B12 and folic acid deficiency, connective tissue disorders, HIV infection, hypersplenism, myelodysplastic syndrome, ITP or immune thrombocytopenic purpura, and very rarely microangiopathic hemolytic anemia. Thrombocytosis, again, we have to approach as primary and secondary. Primary means it is myeloid malignancy. It can be polycythemia rubra vera, CML, essential thrombocytosis. Secondary is usually secondary to iron deficiency anemia, chronic inflammation, infection, and hemolysis. Again, a patient history and physical examination are important to differentiate between two. And in primary, we can see that all the cell lines are affected, except in essential thrombocytosis, where only platelet is increased. Whereas if you take polycythemia rubra vera or CML, all the cell lines will be affected. Whereas in secondary causes, only the platelet will be high. So summarizing, examine the hemoglobin as a general indicator of anemia or polycythemia. Check the RBC count. Check the MCV as a key parameter for the differentiation of anemias, that is macrocytic, microcytic, or normocytic. RDW is a useful parameter in the differentiation of iron deficiency with thalassemia, platelet count, and WBC count to rule out leukemia or leukopenia. Now, another ignored topic is histogram. Histogram provides useful information for the precise diagnosis and management of the patient. Histogram is derived by plotting the size of each cell on the x-axis and the number on y-axis. So these are the histograms which we see in the hemogram. There is a WBC histogram, there is the RBC histogram, and there is a platelet histogram. But histograms, you have to always read it in conjunction with the absolute cell count, and they are not diagnostic of any condition. They will just help to support the diagnosis. Coming to the RBC histogram, instrument will count the cells between 50 to 150 femtoliter as erythrocyte. The RBC histogram is a symmetrical bell-shaped curve. The importance of this curve is that whenever there is iron deficiency anemia, the curve will slightly shift towards the left. If there is macrocytic anemia, the curve will shift towards the right. So that is the importance of this RBC histogram. And you can see that at both the ends, it is touching the baseline. Now, there are certain abnormalities. That is, if the lower discriminator is not touching the baseline, it means it is because of platelet clumps. If the upper discriminator is not touching the baseline, it means that there is RBC agglutination or it is a chronic lymphocytic leukemia. If you see two peaks as shown in this diagram, it means either it is post-transfusion or it is a dimorphic picture or it is an iron deficiency following recovery. So this is a hemogram which shows hemoglobin is low, MCV 69, as we discussed, it is low. Then we look the RDW, which is high, and then platelet, it is high. So this is a case of iron deficiency anemia, and in the histogram, we can see that the curve has slightly shifted towards the left. Next is the hemoglobin is 10.6, which is low, MCV is 117, which is high, RDW is 14.1, which is normal, and platelet is 98,000. Here you can see that the curve has slightly shifted towards the right. So this is a case of megaloblastic anemia. Next is WBC histogram. WBC histogram has got 3 peaks and 2 troughs. At the lower discriminator zone and the T1, between that, the first peak is of that of a lymphocyte, and the cell size is between 50 to 100. The next peak, that is between T1 and T2, is the mixed cell, and it represents eosinophils, basophils, monocytes, and promyelocyte. Here, you can see the blast also sometimes. So whenever you're suspecting leukemia, and if you see a WBC histogram, and there is a peak in the middle portion, it shows that there are blasts. The third peak between T2 and the upper discriminator is the neutrophils. So in the WBC histogram, if you see that the third peak has risen, it means there is neutrophilia. If the first peak has risen, there means it is lymphocytosis. And if the middle peak has risen, it could be mixed cells, that is monocytosis or eosinophilia, but it's difficult to differentiate between these two. Now, platelet histogram, the platelet size is plotted against number, and two parameters are obtained, that is mean platelet volume and platelet distribution width. Mean platelet volume, when it is high, it indicates sickle cell anemia, immune thrombocytopenic purpura, and post-splenectomy. And mean platelet volume, when it is less, it indicates aplastic anemia and megaloblastic anemia, where there are small platelets. Now, I'll be dealing with few spotters. A 35-year-old female came to OPD with complaints of menorrhagia since 5 months. She has complaints of dyspnea on exertion and EC fatigability. She has history of pica. On examination, there is pallor and longitudinal ridges on nails are present. So we'll analyze the hemogram. Hemoglobin is 7.6, which is low. Then we look the MCV, which is 73, which is again low. Then we look the RDW, which is 18.3, which is high. Platelet is also high. So this is a case of iron deficiency anemia with reactive thrombocytosis with a normal total count and differential. In the differential in iron deficiency anemia, always look the mixed cell because there may be sometimes eosinophilia, and hookworm infestation could be the cause of iron deficiency anemia. Next is a 50-year-old male who's a temple priest. He's a strict vegetarian. He came to OP with complaints of numbness of both lower limbs and swaying while walking. On examination, knuckle pigmentation is present. Romberg's is positive. This is the hemogram. Hemoglobin is 5.6, which is again low. MCV is 110, which is high. Then we look the RDW, which is also high. Then the platelet, which is 92,000, that is there is thrombocytopenia. The total count and differential count is normal. So this is a case of B12 deficiency and folic acid deficiency, that is megaloblastic anemia. And since the RDW is high, maybe there is an underlying iron deficiency also. Next is hemoglobin is 8.5, MCV 77.2, which is low. RDW 17.5%, which is high. Platelet is 2.5 lakh, which is normal. And there is a mixed cell 21%. So this is a case of mixed deficiency anemia. Why? Because the hemoglobin is low, MCV is low, RDW is high. So there is iron deficiency definitely. And in iron deficiency, we would actually expect there is reactive thrombocytosis. But here the platelet is normal. So it may be because there is underlying B12 and folic acid deficiency. And the mixed cells is high, maybe because there is eosinophilia. Next is a 23-year-old female who came with complaints of high-grade fever since 5 days, associated with headache and retroorbital pain. On examination, conjunctiva is congested and maculopapular rash is present. Hemoglobin is 11.2, which is normal. MCV is 83.6, which is normal. RDW is 13.3, which is normal. Total count and differential, except for a little increase in mixed cell, is normal. Platelet is 66,000. So there is thrombocytopenia, isolated thrombocytopenia. So it could be because of drugs, as we said, or it could be because of infection. And here, since there is a fever history, we should consider infection, and viral infections, probably dengue. 47-year-old manual laborer came with complaints of high-grade fever since 5 days, associated with myalgia, decreased urine output since 2 days. On examination, patient is dehydrated, icterus is present. This is the hemogram. Hemoglobin is 10.8, slightly on the lower side. MCV is 83, which is normal. RDW is 12.7%, which is normal. Platelet is 72,000, that is there is thrombocytopenia. And total count, you can see it has increased as 30,450, and it is polymorph predominant, that is neutrophil predominant. So in this setting of fever, manual laborer, myalgia, and conjunctival congestion, and very high ESR, we have only two possibilities, that is leptospirosis or malaria. 30-year-old female complains of fever since 10 days associated with headache, dry cough and abdominal discomfort. On examination, patient is sick looking, tongue is coated, there is a soft liver palpable. The hemogram is hemoglobin is 10.9, which is low, MCV is 86, which is normal, RDW is 13.2%, which is normal, total count is 3,800, which is low, the differential is normal, platelet is 2 lakh. So the only abnormality we find here is that the total count is in the lower side. So this is a case of leukopenia, and in the setting of fever, prolonged fever with headache, we have to think of enteric fever, which presents as leukopenia. You will never find polymorphonuclear leukocytosis in enteric fever. A 35-year-old auto rickshaw driver who is a chronic smoker presented with complaints of recurrent headache, no other significant symptom. On examination, he was obese, conjunctiva is congested, there was palmar erythema and blood pressure was 170/100. This is the hemogram. Hemoglobin is 17.5, that is, it is high. Then we look the RBC count, that is 5.83, which is also high. And then the MCV is normal, hematocrit is 52.5%. Other cell lines are normal, the platelet is normal, the total count is also normal. So since there is isolated polycythemia or single hemoglobin increased, RBC count is only risen, no other cell lines are affected, we can come to a conclusion of secondary polycythemia. And there are numerous factors for that. He's a smoker, he is obese, and the blood pressure is also high. A 35-year-old female belonging to tribal community who's a manual laborer came with complaints of high-grade fever with myalgia since 5 days, associated with yellowish discoloration of urine and eyes. On examination, conjunctiva is congested, icterus is present. Here we can see that the hemoglobin is 6.1, which is low. MCV is 81.6, which is on the lower side. RDW 17.6%, which is high. Platelet is 3.14 lakh, which is also high. So there is definitely an iron deficiency in the background, but most importantly, you can see that the total count is rising, that is 22,300, and it is polymorpho predominant. So considering the situation of fever, myalgia, and yellowish discoloration, we have to think of an infection and probably leptospirosis or malaria. Another case, 35-year-old male came with complaints of fatigue, bleeding from gums, and arthralgia. On examination, pallor was present. Hemoglobin is 10.4, which is lower side. MCV is 87.2, which is normal. RDW is 13.8%, which is normal. Then we look the platelet, there is thrombocytopenia 58,000. Total count, it is very striking that it is 78,970. And the differential shows that monocytes is 34%. So this is a case of acute myelomonocytic leukemia. A 30-year-old female came with complaints of recurrent oral ulcers and arthralgia. On examination, pallor was present. This is the hemogram. Hemoglobin is 9.5, which is low. MCV is 89.9, which is normal. Total count is 1,900, which is on the lower side. RDW is 15.4%, which is on slightly higher side. Platelet is 69,000. So you can see that there is pancytopenia. Hemoglobin is low, total count is low, platelet is low. So pancytopenia, we have to approach as rule out common conditions like drugs, infections like malaria, parvoviral infection, hepatitis C infection, nutritional deficiencies, B12 and folic acid deficiency can sometimes present as pancytopenia, not only thrombocytopenia and anemia, they can come as pancytopenia also. And in this background, being a female, recurrent oral ulcers, arthralgia, ESR is 110, we have to think of a possibility of collagen vascular disease also. Next case, 21-year-old male who was studying in Delhi came with history of fever with rigor and chill since 8 days, associated with headache and myalgia, occasional dry cough is present. Hemoglobin is normal, MCV is 82, which is normal, RDW is normal, platelet you can see it is 1.2 lakh, that is it is slightly on the lower side, total count is normal and differential is normal, ESR is 40. So considering the history of fever with rigor and chills, it strikes malaria, and malarial parasite was positive for this patient. So I want to strike that malaria can just come with a low normal platelet, that is thrombocytopenia, and a slightly higher ESR. Another case I want to highlight, hemoglobin is 3.8, which is very low. MCV is 83, which is normal. RDW is high, 18%. Total count is 2,260 and platelet is 80,000. So there is pancytopenia, definitely iron deficiency, and there is pancytopenia and other nutritional deficiencies. This was a case of malaria, a severe malaria. So malaria can sometimes present as pancytopenia also. They can come with thrombocytopenia, they can come with leukocytosis, and sometimes they can come with pancytopenia. Another 47-year-old female, known case of chronic kidney disease on hemodialysis, now came with complaints of tiredness and fatigability. On examination, pallor is present, white nails is present. That is, there are signs of chronic kidney disease. This is a hemogram. Hemoglobin is 7.8, that is, it is low. MCV is 91, that is, it is normal. Total count is 5,800, which is normal. RDW is slightly on the higher side. Platelet is 1.72 lakh. So here the abnormality is that anemia is there. It is a normocytic anemia, probably anemia of chronic disease. And since the RDW is high, maybe there is an underlying iron deficiency also. Since the patient is on hemodialysis, there is automatically chronic blood loss. And that may be the reason for iron deficiency anemia. And this can be confirmed by doing a serum ferritin. So the take-home message is that it is mandatory to take the patient's history and detail and perform a detailed physical examination. And if you get the old records, compare the new result with the old result, and then only go for costly workup. Thank you. Please unmute. Akhil can unmute.
Dr. Akhil, you can unmute yourself. Dr. Akhil. Hello, Dr. Akhil.
Yeah, I hope I'm audible.
Yeah. There you go.
Hello. Yeah, that was a very
Now you're audible.
yeah, that is a very excellent presentation because she has almost covered the whole overview of this very important topic, because there are various layers to it, including RBCs, platelets, the WBCs, the various histograms, the technique of doing CBC, and interpretation of the values. I think within the available time, she has covered it in all. And sometimes, as I previously mentioned, a simple good analysis can do away with various other even bone marrow even. And Mamta, what's your opinion regarding doing iron studies in a patient with iron deficiency anemia? Probable.
I think it will help in iron studies will help in substantiating the diagnosis of iron deficiency anemia when we have a confusion with anemia of chronic diseases.
Yeah, but when you have a low MCV with increased RDW, very often, I think 99% of the time, that alone is sufficient, because nowadays we have a tendency of iron studies, because basically at a peripheral level, when you have as far as cost effectiveness is concerned, I don't think many a time iron studies are beneficial at all, except in cases like maybe, as Mamta mentioned, like an anemia of chronic disease, especially renal failure. Because if you have a low ferritin on analysis of iron studies, maybe before starting erythropoietin, you may have to start iron, or even sometimes consider giving blood to correct the ferritin level before going on to erythropoietin studies. So it's in very specific situations that you may have to proceed with higher investigations, like the example mentioned, like iron studies. So very often analysis of the CBC itself, even iron deficiency can even be diagnosed without the peripheral smear even from a proper CBC. So you can do away with a lot of other higher investigations if you know how to analyze the CBC properly, which you have already discussed in detail. Any other queries from the house?
Sir, in chat box, some questions are there.
Yeah.
Can I read the question for you, sir?
And I'd also like to highlight a few other aspects I think which has not been covered. Other than as far as the platelets are concerned, you have something called as mean platelet volume and platelet distribution width. It's just like MCV and RDW. And maybe in a general practice level, I don't think it's of much use, but there are situations where there can be, even though the platelet count may be normal, you can have variations in the MP mean platelet volume and platelets distribution width, like in pregnancy, where you can have increase in MPV and PDW, and sometimes the platelet may be normal, but you may see a increase in the platelet volume. And the first thing to be verified is whether the blood has been stored, because if the sample has been analyzed after some amount of storage, you can have MPV increase with a PDW decrease. And some other areas of research is in various vascular or inflammatory conditions where increase in MPV and PDW can indicate risk of vascular events, especially. So these are all areas of research. I don't think it may be useful in a day-to-day practice, but just mentioning it for completion's sake. Any other points to be added?
Sir, can I ask a question?
Yeah.
What is the right time to do a blood count after a transfusion? Is there any time cap like that?
Anyway, immediately following, you'll have to wait at least, as Mamta mentioned, there may be what exactly do you want to find out by you meant to see say whether what is the time to see whether the hemoglobin has risen, or
Yeah.
I think as what Mamta mentioned previously, the variation in the RBC histograms, it may take up to 5 to 7 days for the changes to manifest. Otherwise, even within 24 hours, you can get a rise in hemoglobin with each pint that is transfused. Any other points to be added regarding this topic from the audience? This specific point?
In chat box, one question is there. Can you just say a few words regarding CBC in COVID-19?
CBC?
In COVID-19.
Yeah, that's a very important question, because just like in other viral fevers, you may get a low normal CBC, and I don't think there's much different from a usual viral infection as far as CBC is concerned. The diagnosis of COVID essentially has to be a clinical diagnosis, especially the classical symptoms of fever, and you may have a typical cramping like sensation or myalgia at the onset of the symptoms, along with upper respiratory or GI symptoms. Certain patients can have respiratory symptoms predominant without GI, and some patients may come even with just purely diarrhea alone. And along with that, you have the classical cramping sensation of the muscles, generalized cramps at the early phase, and along with that, you have low normal. The count may be normal, but you can have relative lymphocytosis. And the thing to be noted is platelet count will not be too low as far as we have observed here, because sometimes a patient coming with fever and severe thrombocytopenia, it's unlikely to be COVID, because you don't usually get, so far from the data which has been analyzed, severe thrombocytopenia as such is not common. You may have a low platelet or a slightly a mild to moderate thrombocytopenia or a low normal platelet without severe thrombocytopenia or overt bleeding manifestations. And the hemoglobin is also normal. Unlike in other infections like malaria, as Mamta mentioned, apart from thrombocytopenia, you can also get a normocytic pneumochromic anemia. So anemia and severe thrombocytopenia is not very common in COVID infection. Any other queries?
Another question, an anonymous question. What is isolated thrombocytosis? What to suspect first?
Isolated thrombocytosis, as already Mamta mentioned, various it can occur as in the setting of various other myeloproliferative disorders. So obviously you have to go with the clinical examination is very important, because any evidence of the conjunctival congestion, splenomegaly, all will point to a diagnosis of myeloproliferative disorders. And a borderline, sometimes you may get a borderline anemia, a borderline hemoglobin with just the platelet count high. And in such a setting, if the RDW is also on the higher side, it may indicate an iron deficiency anemia, where the hemoglobin may not be on a very low level, but you can have a reactive thrombocytosis even at the early phase. And the rest, I think, analysis of thrombocytosis has already been covered by Mamta in her talk. The clinical examination is very important, because look for any evidence of myeloproliferative disorders like other cell lines like polycythemia, look for splenomegaly and maybe hepatomegaly, sometimes lymphadenopathy, which all will give a clue to what exactly is the cause. And I think the others Mamta has already covered. Any other points to be added? Mamta, can you highlight what can be the clinical implication of RDW standard deviation? Because the usual RDW that you look for is RDW CV.
CV, yeah.
Yeah. ST?
SD, I don't know.
ST, actually, I think it has a very, doesn't have usually a clinical implication, but the only setting maybe sometimes you may get so RDW may be elevated, falsely elevated. The CV may be elevated, where sometimes if you have a homogeneous population of cells with low MCV.
Okay.
And sometimes even in a patient with high MCV, with a heterogeneous population, the RDW may be normal. So if you have any doubt in, if you are suspecting iron deficiency, but if the RDW CV is normal, it can be because there can be associated high dimorphic anemia with high MCV cells, which will lead to normalization, sometimes lead to normalization of the RDW CV, where rarely you may get a slightly better picture from analyzing the RDW SD, because it actually gives a true measurement of the red cell distribution. So usually there's not much information gained from RWSD, but sometimes have homogeneous population of low MCV cells or heterogeneous population of high MCV cells can lead to errors in RDWCV, where RDWSD can give you a better idea of what exactly is happening. And I just wanted to add that sometimes enteric fever can present with a typical hemogram like a viral fever, because early enteric fever you can have just a fever, headache, myalgia, a dry cough, just like a simple viral upper respiratory infection. You can have normal WBC and neutrophilia may not be there. There may just be a slightly higher lymphocyte. So you may suspect it to be a simple viral fever, but sometimes looking at the ESR can give you an idea that it may not be a true viral infection, because normal viral fevers, you won't get a very high ESR unless there is some other cause responsible for high ESR. So an early viral fever like picture, both clinically and in the CBC, a high ESR should make you suspect enteric fever. So that's just another point which I wanted to add. Any other questions or queries?
There's another question. It's not completely related. Importance of lymphopenia in COVID-19.
Importance of leukopenia.
Lymphopenia. Leukopenia, it means.
I think the questions are shifting from CBC to COVID
CBC.
infection, but
Someone
but
has
anyway,
asked
I
that
don't think analysis of CBC has not much role, as I already mentioned. The typical WBC pattern in just like other viral infections may be there. Severe thrombocytopenia should make you consider other infections other than COVID, even if COVID is so rampant, because there may be a tendency to label everything as COVID and unnecessarily subjecting to swabbing. But analysis of the RD of the CBC itself can make you think about an alternative diagnosis. Lymphopenia, as far as maybe I'll have to look into that. I don't know whether it has any significance, because usually you get neutropenia, leukopenia, or low normal WBC count with slightly higher lymphocyte count. And maybe in the early phase, you may have a slight neutrophilia, but lymphopenia as such, I'm not sure. I don't think it has too much of a clinical implication as far as the present knowledge of COVID-19 is concerned. Any of the audience can correct me if you have other opinion. But as far as I know, this my knowledge.
If anyone has any doubts, you can just unmute and ask. If no more queries, I think we can wind it up. It was an excellent session by Dr. Mamta, and nice discussion just led by Dr. Akhil. Thank you both. I would like to ask Dr. Nestla, institutional representative for Spicewood from Calicut Medical College, to express the vote of thanks for this gathering. Over to Nestla. Nestla, please unmute and speak.
Okay, am I audible? Hello, am I audible?
You are audible.
Okay. Good evening, all. I'm Dr. Nasla, junior resident from Department of Family Medicine, Calicut Medical College. I'm here to deliver a vote of thanks. So first, I would like to thank Spicewood Kerala for giving me this opportunity. Next, I would like to thank our Dr. Mamda for her excellent presentation. It was such an extensive and informative session, and it was so useful to us, especially junior residents. So I thank Mamda for her wonderful presentation. Next, I would like to thank our beloved Akilka for being with us and chairing the session and the very informative discussion. And I also expect your support in future sessions also. Thank you, Akilka. And I would like to thank all the participants, and I request all the participants to be with us in future sessions also. Thank you all, and good night.